we have Dr. Lindsey, who is going to be giving us his theory.
Hello. So the presentation I'm going to talk about today is off-road pharmacy using PCSK9 inhibitors for the management of cholesterol. And you'll see that they're not calling it off-road pharmacy because they don't really fit into the current guidelines right now. So how we're going to go about using them to treat people with elevated cholesterol, it's kind of up the air. So for those that aren't aware, the PCSK9s are a new group of medications that just recently come to market for the treatment of elevated cholesterol, particularly LDL. They're indicated right now in conjunction with maximally tolerable statin therapy for people that have clinical atherosclerotic disease or one of the familial hypercholesterolemia conditions, homozygous or heterozygous. And just very briefly, their mechanism of action, the way they work, they're fully human monoclonal antibodies specifically target the PCSK9 protein, which under normal circumstances would bind to LDL receptors in your liver and cause them to degrade. So if you can take that protein out of commission by using this antibody, those receptors remain in the liver and are able to remove LDL from the circulation, so your LDL levels decrease. That's just a really quick overview. In general, with the studies they've done to bring these drugs to market, they've noticed 40 to 60% LDL reductions on top of what was already going on with the statins. Some differences with these as far as the statins go, these are injectable versus oral, they're both sub-Q. The Praluent, which came to market at the tail end of July, comes in a 75 milligram and a 150 milligram pre-filled syringe. These both have to be refrigerated before use. With the Praluent in particular, you want that one to come to room temperature, give it about 30 or 40 minutes, and then administer it. If it has been stirred from the refrigerator for an hour or more, you can't use it. With the Repatha, which came to the market in August, that one comes in a 140 milligram pre-filled syringe. And with that one, you can administer it either as one pen every 2 weeks. The Praluent is also dosed every 2 weeks. Or this one has the indication if you're using it specifically for the homozygous hereditary condition, you can give 3 of the pens simultaneously, 30 minutes consecutively, and do that once a month to treat the homozygous condition. And that one can have a longer excursion. You can actually leave that one out in the refrigerator for up to 30 days and it's still going to be good. One of the big issues with these is that they are incredibly expensive. The manufacturers that are marketing these have done the pricing based on what they consider similar medications. In their case, they're comparing it to hepatitis C medications, and the similarities that they're drawing are that the hep C medications are relatively new. There haven't been any medications recently that are used to treat that particular disease state, and you have a very large potential patient population that can benefit from it. So that's how they're coming up with the pricing. A key difference that they kind of failed to address with that is that the hep C medications are designed to be curative, so you're not going to be on those long term, hopefully. These are designed to treat lipids, so you're going to be on these for a lifetime if you're going to be put on this. So you've got high cost going on until you reach the end of your life. So what they're trying to do now is the PBMs are trying to kind of play the two companies off of each other and bring the price down, kind of limited with hep C medications, but that's still relatively new, so that hasn't really had much impact on pricing so far. The problem with it is the way that they're marketed and the way that they have their indications. They're marketed for additional LDL lowering. The guidelines don't currently use treat to target as a strategy, so how can you use these for additional LDL lowering if you're not targeting LDL according to the current guidelines? So since we brought up the guidelines, ACC and AHA came out with new cholesterol management guidelines in 2013. And in these guidelines, they identified 4 groups that could potentially benefit from statin therapy. And I've included that breakdown on your final sheet if you have a handout if you want to look at those, just for your benefit. But in identifying those 4 groups that could benefit from statin therapy, they only address statins because in reviewing these guidelines, they only looked at data from randomized clinical trials. They didn't really look at any other data because they consider that to be the gold standard. And based on the randomized clinical trial data, there wasn't really any evidence that supported the fact that you should be treating to a particular LDL goal. which is something that they cited in the new guidelines. Three particular issues they brought up with the treat to target approach, that the data didn't really support that based on the data that they were looking at, it's really not known if you get any additional morbidity mortality benefit by saying we're going to treat to this goal like lower than this goal. There's not really anything that supports that. And they don't really account for any adverse reactions from multi-drug regimens that these patients might be on. Something that's been suggested in terms of potentially folding these into these guidelines, that they might be added into the high intensity treatment group, which would be reasonable, but they're going to kind of get into the whole, well, the high intensity, you're still kind of putting into that category because of what they do to LDL, so when you're still kind of treating based on a target. But if you throw that out the window, these could potentially end up being used in lower intensity treatment categories, in which case you've got these really expensive medications running rampant, and it becomes an issue for patients and payers. So after these were released, CBS released an article in JAMA at the tail end of August, basically saying that we should go back to a treat to target approach. And the way that they backed that up was saying that this fits with the way that these medications are indicated, that you're treating towards an LDL goal, so you don't have to worry about that. And they have those concerns that these could potentially be used in the lower intensity groups, in which case you have more people that are going to be on these, and it's really expensive really quickly. You've also got the FDA advisory panel saying that these should be limited to people that only have that genetic disorder, and if you're just have elevated LDL or clinical cholesterol issues, that these medications are something that you should use sparingly. Now, the concern with that is even though the advisory committee made that recommendation, we have brand new drugs to use for cholesterol treatment, so people might not necessarily pay attention to that. Another reason I want to go back to LDL is looking at it from a payer perspective. If you actually have a target to treat, that makes it easier to use standard drug utilization tools in terms of determining what you're going to pay for, what you're not going to pay for, that sort of thing, which makes sense because CVS is one of the biggest PBMs in the country. So it makes sense that'd be something that they're interested in. Another thing they point to is the fact that there are other lipid management guidelines that still utilize LDL goals, and they listed several in the article. So after the article came out, there's been a little bit of backlash, and people have had some criticisms about the article. One of which is the fact that CVS is typically thought of as a pharmacy company, and yet none of the authors for the article in JAMA were pharmacists. And some people felt that maybe they didn't include pharmacists in that because maybe they felt that they lacked competency to comment on it, or maybe the pharmacists in the company didn't necessarily agree with the recommendation being made. We don't really know, that's all speculation, but it was something that was mentioned. Another criticism is that pharmacists could actually liaison with prescribers, and in that way limit the way that PCSK9 inhibitors are used. But in particular, there's the argument that maybe community pharmacists don't have time to do that, and they need to be regulated another way. Another criticism is that some of the phraseology in that particular article kind of downplayed the capabilities of prescribers. And I've included a quote in there from that, but basically it's saying that they have to complete balancing multiple competing priorities and clinical decision making, efficacy, safety, evidence quality, as well as responsible stewardship of limited healthcare budgets. I thought doctors did that anyway, but based on the way they phrase it, it kind of sounds like maybe they don't think so. And the other recommendation is the fact that we've said it makes sense that they focus on economics, but one of the criticisms is that that article focused only on economic benefits of going back to LDL goals. And you're basically putting yourself in a situation where you're treating a number as opposed to a patient, and you're looking only at the LDL and not the overall patient's healthcare status. So that's where we are with that right now. There hasn't really been anything done about this so far. These are still relatively new. The guidelines haven't really had a chance to get updated with that. They are actually still backtracking from some other information that's come out, like the improvement trial. They haven't taken that into account in terms of cholesterol management and that sort of thing. So it will definitely be something to keep your eyes on. So, are there any questions? Okay. Either one of you?
In those trials of the new drugs, did they look at event reduction, and were there any changes in cardiovascular events in the patients who got the new drug?
The trials that brought the PCSK9s to market, they did not look at that. So what they were looking at was primarily LDL reduction. That was the primary endpoint that they were looking at with the trial to prove efficacy with the PCSK9, so that's something else to take into consideration.
And just a comment on that, I don't think those trials, they are in the process of doing morbidity and mortality studies with these drugs, so I don't think they'll be out until about 2017.
Yeah.
I think you talked a lot, sort of about cost, and about some criticism of these agents. Not like evidence that who is an agent usually considered these agents.
So that's, again, one of the things we don't really know, because the way that they're marketed is for additional LDL lowering. So what they're going for is if you've got somebody that's on maximally tolerable statin therapy, so you could make the argument they can't tolerate a statin at all, we can jump straight to this. And based on the way that it's marketed, that's okay. And you're having additional LDL reduction. Based on the guidelines, we don't know who's eligible to be treated with these. And that's kind of the whole issue. All right, well, I appreciate y'all being a great help.